Hello and welcome. Thank you for joining us today. My name is Steinberg, and I developed the semi-structured clinical interview for dissociative symptoms and disorders, the SCID-D for short. It's an honor to be here with you virtually at the invitation of my colleague, Dr. Ellen Jepsen, to mark the occasion of the SCID-D's new translation into Norwegian and to speak to you briefly about this powerful diagnostic tool that can help survivors of trauma regain their voice. What does this image say to you? What does it represent? If this woman could speak, what would she say? This image represents the reason I developed the SCID-D. For so many trauma survivors, it can be difficult, even impossible, to express their authentic feelings. There is a code of secrecy surrounding abuse. To survive, trauma survivors learn not to talk about their experiences. And it's easier to not talk about what you can no longer feel. And so they learn to disconnect from their feelings. They go silent, inside and out. How do we, as therapists, gain insight into a person's inner world and life experiences when they can't tell us directly? In order to overcome these difficulties, the SCID-D was designed to ask people how they survived. Did they develop coping mechanisms related to disconnection from themselves or other people? There is no code of secrecy about that. Survivors need us as their advocates and as therapists to assist them in speaking freely. When I was developing the SCID-D at Yale School of Medicine in the 1980s, there was no systematic method for diagnosing dissociative disorders. The three main approaches during psychotherapy, hypnosis, and drug-assisted interviews posed risks. In psychotherapy, diagnosis could take months, if not years, until the emergence of an alternate personality. With hypnosis, there was the risk of claims of iatrogenesis and controversy about the accuracy of recalled memories. With drug-assisted interviews, again, there was controversy over the accuracy of recalled memories and the additional risk of patient decompensation. Clinicians were also taught to look for red flags, such as a person experiencing many symptoms that seemed to fluctuate over time, which might raise one's suspicion for what was known as multiple personality disorder. These symptoms, however, could accompany many other conditions, such as depression, anxiety, or bipolar disorder. In short, none of these methods could reliably distinguish a dissociative disorder from the many psychiatric disorders with similar symptoms. I developed the SCID-D to solve this problem. To diagnose dissociative disorders, the interview explores 5 primary components of dissociation that, in various combinations, are diagnostically distinctive. These 5 components are amnesia, depersonalization, derealization, identity confusion, and identity alteration. I called these components, rather than symptoms, to avoid pathologizing these extremely common ways of coping with all kinds of trauma. In other words, I designed the SCID-D to focus on the adaptive responses to trauma, which represent a person's resilience, instead of identifying a problem or symptom. Behind the many overt manifestations of dissociation, depression, anxiety, substance use, eating disorders, suicidality, and so on, stand these core components: If we treat the person with dissociation for symptoms in the outer ring, they will continue to seek treatment for the underlying dissociation. On the other hand, if we treat them for these trauma-related defenses, the symptoms in the outer ring will be diminished. Individuals with dissociative disorders are often misdiagnosed or in treatment for a comorbid diagnosis for many years until the correct diagnosis is made. Common past diagnoses include anxiety or mood disorders, ADHD, personality disorders, psychosis, as well as substance use disorders. Just like a chest X-ray can detect pneumonia, the SCID-D interview can look at the internal components of dissociation. The 5 components present along a spectrum from subclinical, which refers to without dysfunction or distress, to problematic, resulting in dysfunction and/or distress. Persons with dissociative disorders have distinct profiles with different mixtures of the 5 components that distinguish them from persons with other psychiatric disorders and from persons without psychological problems. The 5 components of dissociation are universal symptoms of trauma-related dissociation. In this next slide, we see all the countries where the SCID-D is being used. It is exciting that researchers have found virtually identical manifestations of the 5 SCID-D components, even when different external behaviors and cultural bound syndromes are observed. This provides further evidence of the universal nature of the 5 SCID-D components. This image, representing data from 12 international replication studies, shows the distinct profiles of persons with dissociative disorders as compared to people with other psychiatric disorders and persons without psychiatric conditions. You can see that the SCID-D profile for dissociative disorders is distinctly different from that of persons with other psychiatric conditions and from normal controls. In addition, the profiles for each of these 3 groups are virtually identical across cultures. It is not surprising that the 5 components of dissociation are universal adaptive ways people survive trauma. According to Bessel van der Kolk, dissociation is the essence of trauma. As mental health clinicians, we're practicing during an exciting time, a time where trauma-informed care is now considered the best practice for treating our clients. I believe that in order to truly be trauma-informed, we as clinicians also must be dissociation-informed. Given the unfortunate high prevalence of trauma, every client should be evaluated for dissociation to rule out dissociation as a source of distress. Finally, the SCID-D itself serves as a therapeutic tool. The interview fosters resilience in that questions are focused on assisting the client to view their dissociation as an understandable coping mechanism and to connect to and learn about their most functional aspect of their personality, encouraging them to promote self-compassion. As you gain familiarity with the SCID-D, you will learn about all the 5 components, how to evaluate and score them, and how they fit together to form dissociative disorders. You will also learn how to interpret the interview's results to arrive at a reliable and sensitive diagnosis and to effectively communicate these results to clients in a manner that enhances your therapeutic alliance and fosters client mentalization. I'd like to thank the 6 Norwegian translators, all psychiatrists and psychologists working with trauma survivors, who sensitively and meticulously worked to translate the SCID-D. Special thanks to Ellen Jepson, who interfaced with me on clarification of questions and final editing. Not only were these colleagues involved in the translation, but as clinicians, they were able to ensure that the wording made sense to clients and would be practical and useful in your day-to-day clinical work. You are fortunate to have Modimbod available as a resource for state-of-the-art compassionate assessment and treatment of survivors of trauma and dissociation. There are, unfortunately, many countries where such resources are not available. Now that you have a reliable instrument available for early identification and treatment planning for dissociation, clinicians trained in the SCID-D can prevent misdiagnosis, reduce patient suffering, and improve treatment outcomes. By the end of this conference, you will be better equipped to help survivors reclaim their voices, to help them speak freely and recover their truest, most authentic selves. Thank you all for being here today, and enjoy this workshop. For those of you involved in clinical research, please feel free to contact me if you have questions about the use of the SCID-D in your project.